Hello, everyone. Welcome to Frontier Nurses University celebration of Nurse Practitioner Week. I am Dr. Lisa Chappell, the Associate Dean of Family Nursing, and today our session is with Dr. Jess Calohan. Dr. Calohan is a DNP, and he's an Associate Professor and the Department Director for the Psych Mental Health Nurse Practitioner Program at Frontier. He is a board-certified psychiatric nurse practitioner who recently retired from the United States Army after 20 years of distinguished service. He earned a BSN from Eastern Washington University in 1987, a Master's of Nursing from University of Washington in 2005, and a doctoral degree, a Doctor of Nursing Practice from the University of Washington in 2012. Dr. Calohan has over 18 years of experience treating service members with PTSD, both deployed and non-deployed members. He is recognized expert in treating combat-related PTSD, presenting nationally and internationally with multiple peer-reviewed publications. He received the prestigious A designation by the United States Army Surgeon General in 2013. This honor is given to less than 5% of the Army medical officers in recognition of their expertise and significant contributions to military members. He served as a program director for the Psych Mental Health Program at the Uniformed Services University of Health Sciences, which trains about 90% of all active duty nurse practitioners for the Department of Defense. Dr. Calohan also maintains a telepsych practice, which services rural and underserved populations. So, Dr. Calohan.
Thank you, Dr. Chappell. I appreciate the introduction. And today we're going to be talking about evidence-based prescribing practices in treating post-traumatic stress disorder. The majority of my experience is obviously with the military population and treating combat-related PTSD. However, in my clinical practice, now working for 2 rural health centers and 1 federally qualified health center, I've been seeing a lot more post-traumatic stress disorder in first responders and also victims of sexual assault, and in some cases multiple sexual assaults. And so there's a lot of applicability of this content across a wide range of populations. In terms of evidence, though, there hasn't been an incredible amount of evidence in the first responder population in terms of treating post-traumatic stress disorder, nor in folks that have been victims of sexual assault. There is, however, a significant amount of evidence on treating combat-related post-traumatic stress disorder. And the reason for that really has to come down to population and funding and things like that. In the mid-2000s, there was a significant amount of funding mid 2000s to 2015-ish or so. There was a significant amount of funding that the Department of Defense put into researching treating post-traumatic stress disorder, and it just has not been extensively studied, unfortunately, in the first responder population and the general civilian population. But like I said, the concepts in this particular presentation will address a wide range of PTSD, because PTSD is PTSD in terms of what's going on for the most part physiologically. And so we're going to focus on that, and I'll draw some parallels to the civilian population as well. Okay, so our objectives. First, disclosures. I'm going to be talking about a lot of off-label uses of medication. Pretty much everything we do in psychiatry for the most part is off-label, and a lot of medications do have indications for certain disorders, but as you're going to see with post-traumatic stress disorder, there's only a very small handful of medications that actually have FDA indication. However, as we look at the classes of medications, mechanism of action and things like that, they're generally the same as those medications that have the indication. And I have no conflicts of interest to disclose. Okay, so our objectives, we're going to talk about the neurobiological underpinnings of PTSD. We're going to analyze the evidence-based pharmacological treatment interventions for PTSD. I'm going to cover a wide range of broad medication categories, for example, antidepressants, antipsychotics, hypnotics, those sorts of things. We'll talk about a couple of standardized screening tools. And then also gonna wrap up with some community referral resources, as well as, I think this is an appropriate place to talk about care models in treating mental health in general. Okay, so it's important to understand the diagnostics of PTSD. So the DSM-5 came out in 2014, and it reclassified post-traumatic stress disorder from the anxiety disorder spectrum. So post-traumatic stress disorder was kind of looped into anxiety disorders. And so when we think about anxiety disorders, generalized anxiety disorders, panic disorders, obsessive compulsive disorders, those sorts of things, okay? So what the DSM-5 did was it took any kind of trauma and stress-related disorders and put them into their own category. And so some examples of that are acute stress disorder, obviously post-traumatic stress disorder, reactive attachment disorder in kiddos, disinhibited social engagement disorder, which I have never seen, and then adjustment disorders, which are situational disorders that can result in psychiatric symptoms. So, for example, somebody loses a relationship and they're feeling anxious or depressed, and that goes on for several weeks, a month, whatever. They're just not kind of coping with it well. It would be a situational related disorder, so we'd call it an adjustment disorder with whatever the mood symptoms are. And then, of course, the DSM is famous for other specified or unspecified disorders. That means we can't quite put everything into one of the diagnostic categories, so we may call it trauma and stress-related disorder unspecified. Not as common with this disorder process as it is for other things like depression and anxiety. Okay, so the criteria for post-traumatic stress disorder is the first criteria is the person has to either experience directly or indirectly witnessed or confronted with an event involving actual or threatened death or serious injury or threat to the physical integrity of self or others. So that has to be the first criteria. In other words, there has to be an event that the person has experienced that to meet this particular criteria. Okay. Criteria B is actually, let me just back up a second. This used to say that involved intense fear, helplessness, hopelessness, or horror. And they took that criteria out specifically because of two populations, the military population and first responders. And the reason why they took that criteria out is because those folks are exposed to training that puts them in these kind of potentially life-threatening events. And what we found was that, or what was found was that people didn't experience that hopelessness, helplessness, or horror during the event. They might have experienced it afterwards, but not during the event. And so some folks were interpreting that as if it didn't happen during the event, that they didn't meet the diagnostic criteria. But for example, the training that the military goes through, and I'll give you just a quick anecdote. One of the things that the military does is that when they're practicing shooting, they shoot on a gun range with silhouette targets that look like people. And that's to help desensitize folks to being able to pull the trigger in a life-threatening situation. And there was an evolution of the types of targets that the military has used over the years. And in World War II, they found that using just paper targets, that many military members, when they were in actual combat, they couldn't pull the trigger at another human being. And so one of the things that happened was they evolved the silhouette target to desensitize them. And then in first responder training, dealing with simulated scenarios, firefighters rushing into a burning building that's for training purposes. Again, so they didn't meet that diagnostic criteria because they didn't have that helplessness, hopelessness, and horror. They ended up, so the criteria was removed, in other words. Okay, so criterion B, re-experiencing in one or more of the following. The person has intrusive or recurrent recollections of the event. In children, it's repetitive play. So sometimes in children, they will they'll play out the traumatic event. And unfortunately, sometimes we see this in sexual assault and playing with dolls and things like that and reenacting some of the things that have happened to them. Recurrent dreams, frightening dreams without recognizable content. In children, in adults, they definitely remember the dream. They feel like they're in the situation, and they'll wake up with a fight or flight type of a response. Dissociation. This is an action or feeling that the event were recurring, or that they're kind of outside themselves, watching the event happen to them. Intense psychological distress, exposure to internal and external cues that resemble the event or that remind them of the event. So this would be, let's say, for a first responder. If they had a lot of traumatic events, they may hear a fire truck or an ambulance coming around the corner near their house, and they automatically go back to the situation that they were in. For a service member, they may see a particular story that that may remind them of it, and that may take them to a place where they are back in the event again, for example. Okay, avoidance. This is 3 or more. So they have to avoid thoughts, feelings, or conversations related to the trauma, activities, places, or people that arouse those recollections. So the avoidance criteria is they don't like to go out in social places. They may not interact with people that they work with. And they, I've had some folks that just kind of stay in their bubble, for example. So they go to work and they come home and that's it. They may not remember any kind of important aspects of the event, and they have this kind of perception that the world is just a negative place, and that everything is bad, for example. If you start to hear guilt in the theme of post-traumatic stress disorder, that is significantly correlated with risk in terms of suicide. So if you're hearing kind of this guilty thing, I should have done this, I could have done more, I couldn't save my buddy, I couldn't do this, then that really should raise some red flags that this person might be at risk for some self-harm. They're in this kind of persistent negative emotional state that looks like depression, and sometimes it gets misdiagnosed as depression. And so we have to kind of look at the chicken or the egg kind of a thing. Did the PTSD symptoms come first, or did the depression come first? So if the PTSD symptoms come first, the depression is actually part of the post-traumatic stress disorder. From a treatment perspective, does that really dictate any difference in terms of what we do to treat it? Not necessarily, because we use antidepressants medications for treating post-traumatic stress disorder as well. Okay, feelings of detachment. They just can't emotionally connect with folks, and they may not even be able to emotionally connect with their families, and that can create a significant issue, obviously, for intimacy and relationships and things like that. And then everything is just blah or negative. They really don't have, any kind of positive experiences. Everything is negative. Okay, criterion E, difficulty falling asleep. They can have some irritability and anger outbursts, which is very common. Oftentimes I hear people tell me that their frustration threshold is super low. In other words, it doesn't take them that long or that much to kind of put them into an irritability or anger. They'll tell me, people describe feeling kind of on edge. There's 2 reasons for that. One, there's the kind of hypervigilance that goes along with it, kind of being aware of your environment, overly aware of your environment. And then there's the irritability component as well, that it just does not take nearly as much to cause them to be very reactive. Here's that hypervigilant response right here, the exaggerated startle response. And sometimes people will engage in reckless or self-destructive behaviors. And part of the reason why is we saw this a lot in military service members. They're deployed for a certain number of months. Their new baseline in terms of their ability to kind of settle down kind of shifts up, meaning that they really never kind of get to a relaxed state. And in that, as we'll see when we talk about the neurobiology, that really creates kind of a chronic, varying degree of fight or flight response. And so people will engage in self-destructive behaviors to feel that kind of high, to feel the quote adrenaline rush. And I've had people tell me that they ride a motorcycle 150 miles down the freeway, jumping out of perfectly good airplanes for sport. And those types of kind of high risk behaviors. It was so significant at one point that the military actually developed some of these high risk activities in a controlled environment for service members to participate in, where there was a lot of safety nets in place to help prevent them from harming themselves, but they were able to get this adrenaline rush. Now, the only distinguishing factor really between acute stress disorder and post-traumatic stress disorder is the time. And so PTSD is more than a month. And so if people are having symptoms of PTSD before they've had them for a month, it's called acute stress disorder. That's really the only in really significant difference between post-traumatic stress disorder and acute stress disorder. Is with any mental health disorders, this particular criterion that has to have significant distress or impairment in functioning, meaning it has to impair them in one of three domains: intrapersonally, so inside themselves; interpersonally, with their relationships with maybe significant others, family, close friends; and then socially or occupationally, so missing work, not performing at work very well, not being able to go out and socialize and go to restaurants and the mall and some of those sorts of things. So it only needs to occur in one of those domains for it to be considered functionally impairing. And then, of course, it's not attributable to any other kind of substance or medical condition. Okay, so let's just talk about kind of the normal response of trauma and what that looks like. Really, the response to trauma is totally evolutionary. It's very protective. And if you think about it, all the way back to Neanderthal times and caveman times, they didn't go out after dark. They stayed in their caves because they didn't want to get eaten by animals. And if they did see a dinosaur or something, for lack of a better term, that was coming at them, the fight or flight response kicked in, and they were, and they would get themselves out of the situation. But there would be this kind of a tail to the anxiety that they experience. And the closest thing that I can maybe draw a parallel to is, has anybody ever had an experience where they were in a near miss car accident? And if you've had that experience, I would ask, how long did it kind of stay with you? In other words, how long did it kind of stick around? And for many folks, it's hours, where there's still that kind of kind of keyed up and really having that adrenaline rush and fight or flight response, and they're still thinking about it, and maybe the person has a dream or two about it that night. But generally, after several hours to a day or two, then things start to kind of go back to a normal type of a situation for the individual. So again, these are normally perfectly acceptable reactions to help folks really survive life-threatening situations. Okay. Now, the problem is that when these reactions become persistent and kind of stick around and interfere with the functioning, then they no longer become adaptive. Then they start to become kind of pathologic. Okay, so when we look at adaptive recovery, I've already kind of touched on this. The person, the recollections become less intense, they become less frequent, and it takes more to cue them to to the type of reaction. So for example, it has to be something very, very specific. Maybe they drive by the intersection where they had the near miss, and that triggers them. But driving out of their driveway, going to work or whatever, if they're not going by that intersection or whatever, then they're not having that kind of memory that's going to cue the reaction. Okay, and then again, the avoidance lessons in the individual, and they gradually relearn that the world isn't always such a bad place, and not always something significantly bad is going to happen to them. Okay, the acute physiological response decreases, and as I mentioned, the world isn't such a dangerous place. And if they have some guilt and shame about it, say they caused the accident or something, then that generally gets better over time. Versus maladaptive non-recovery, the initial reaction persists for more than a few weeks. The symptoms are very distressing and significantly interfere with their functioning, and really they just get worse rather than better over time. Okay. The individual continues to have excessive re-experiencing symptoms, avoidance, arousal, and feelings of shame or guilt. And again, here, if you hear this kind of stuff, really need to do a risk assessment and assess for suicide. So when we talk about treatment, we're generally talking about treating, the re-experiencing, the arousal, and those mood symptoms, those negative mood symptoms that we were talking about. And then, of course, if they're suicidal, then we need to, help them put measures in place to keep them safe. Okay, so let's talk about emotional memory. And our emotional memory is really kind of at the core of post-traumatic stress disorder. All right, and this happens, on a daily basis for us in terms of memories that occur. And so really the primary system that's involved in emotional memory is the limbic system. And so the cingulate gyrus in the limbic system, it's really what receives the information. So it's a sensory sensory structure in the brain. And then the hippocampus, the hippocampus is kind of analogous with a flashbulb on a camera. Okay, so it's capturing the memories. All right, it's capturing those memories. And then the amygdala emotionally codes those memories. So it says, oh, these memories are related to good emotions, or these memories are related to bad emotions, and then, or negative emotions. And then the thalamus is kind of the translator of that in the relay station that helps perpetuate that emotional response throughout the brain. So anybody ever have a certain smell that smelled so good, and it reminded you of a great experience in your life, and 20 years later you smelled the same smell and it took you right back to that experience? Okay, I'm sure that some folks have had that experience before. That is a great example of the hippocampus, amygdala, and just the overall limbic system playing a role in capturing our memories. Our sense of smell, interestingly enough, when it comes to emotional memories, is actually the strongest sense. And part of it's because the olfactory bulb is in close proximity to the limbic system. And so it's not uncommon for me to hear military service members say things like, burning rubber, diesel fuel smells, those sorts of things automatically take them back to a negative memory. Same thing in first responders. And even same thing in sexual assault victims, where they remember a certain smell or a certain something from the event, that when they smell that smell, it takes them right back to the event. Okay. These structures are involved in long-term potentiation, which is effectively long-term memory formation. And again, it attaches behavioral significance and a response to whatever the stimulus is, and in this case, the memory. Okay. All right, so let's talk about stress in the HPA axis. Oh, this did not translate over well. Those half moons are supposed to be arrows, so I will go through that. So the hippocampus, the amygdala, and the hypothalamic pituitary axis are the primary circuits that are involved in managing stress, or our fight or flight response. So when we have a normal response, a normal stress response, the HPA axis releases a corticotrophin releasing factor, which is a centrally located hormone in the brain, which stimulates adrenocorticotropin releasing factor from the pituitary. and then stimulates the glucocorticoids to be released from the adrenal glands. So those all increase. And then when the glucocorticoids levels get to a certain response or a certain level, they bind to receptors that shut off corticotrophin releasing factor and stop the stress response. Okay, so that's kind of a higher level example of the stress response. Now let's look at what happens with specific neurotransmitters during the stress response. So when we have the stress response, the release of glutamate occurs as well in norepinephrine, and that increases the fight or flight response. And when we think about glutamate, glutamate's the primary excitatory neurotransmitter in the brain, and GABA is the primary inhibitory neurotransmitter of the brain. When we start talking about things like serotonin and norepinephrine and dopamine and histamine, those are kind of the fine tuners. So when you look at, when you think about a radio in your car and you hit scan, that scan is kind of going to get you in the ballpark of where the radio stations are at. So that's kind of glutamate and GABA kind of functioning, right? But then you turn the dial individually to get to the station where it's crystal clear, and that's kind of the role of the monoamines, in this case, norepinephrine, dopamine, and serotonin. They're kind of those fine tuners. And glutamate and GABA kind of get you in the ballpark and are kind of the upstream neurotransmitters, if you will, and then those other, the monoamines, are kind of the downstream ones that do the fine tuning. Okay, so in this particular case, GABA is primarily inhibitory, so it attenuates glutamate, and norepinephrine, and the fight or flight response stops. When we look at post-traumatic stress disorder, though, that isn't necessarily what happens. The HPA axis negative feedback loop is dysregulated, meaning it's out of control. And so what we see kind of in the near term is we see a hypercortisolism in the blood, and so their cortisol levels are incredibly high. But over time, they're talking months to years. What happens is those receptors, those cortisol receptors, become desensitized, and then you see kind of this externally kind of this decrease in cortisol or low cortisol levels. And so what happens is that the cortisol systems kind of burn out, and then but the brain doesn't quite figure that out. And so corticotrophin releasing factor still is being released in the brain, which happens to stimulate norepinephrine from one of the primary neurotransmitter centers called the locus coeruleus. And then what happens is when the person's kind of already in this kind of heightened state of arousal, it actually can cause morphological changes in the brain. We see shrinking of the hippocampus. We see the amygdala also shrinking, and then in the long term, you can see changes in the prefrontal cortex in terms of a reduction of brain volume, which can lead to other things. And then, of course, there's alterations in neurotransmitters. Serotonin goes down, norepinephrine goes up, GABA goes down, and glutamate goes up. So essentially, what we've created is this hyperactivity type of an environment within the brain, which perpetuates the post-traumatic stress symptoms, particularly the anxiety and hyperarousal. Okay, so there's some other neurobiological theories that are starting to be kind of studied, and also are the maybe potential targets for treatment. One of those is the endocannabinoid system. In fact, there's been a fair amount of study on CBD and marijuana with treating PTSD, and the evidence is actually starting to look pretty good, but there's still a long way to go with that. And then GABA B receptors, which are specific receptors that also perpetuate serotonin. So when they're activated, serotonin's released, and so you get this kind of this inhibitory response that begins to attenuate norepinephrine and glutamate in the brain. And then other substances, brain-derived neurotrophic factor. Those are things that help really perpetuate synaptogenesis and neurons forming better connections, and also protect neurons in the brain from hyperexcitatory state. Oxytocin and substance P. Substance P is obviously related with pain, and so there's been several studies that have looked at levels of substance P in folks that have PTSD, and those levels are substantially increased. And in fact, it's not uncommon for us to see kind of some chronic pain conditions in patients with post-traumatic stress disorder. So we're not only managing, the disorder, but now we're managing a chronic pain kind of a scenario. Okay, so let's transition into pharmacotherapy. So PTSD is incredibly difficult to treat. In other words, there's not a one-size-fits-all. There are some clinical practice guidelines that talk about first, second, third, and fourth line drugs. But the issue is that PTSD is not PTSD. In one person it is, and another person is another person. So there's this heterogeneous symptom presentation. The other thing is that there have been very few drugs that have come out really within the last 10 to 15 years that had FDA approval for PTSD. Whereas we look at things like antidepressants for depression, we look at things like antipsychotic medications. I think there was an antipsychotic medication that came out last week. But there has not been any kind of significant innovation from a pharmacotherapy standpoint in many years for post-traumatic stress disorder. Oftentimes there's comorbid disorders that are occurring with the post-traumatic stress disorder. We kind of talked about that chicken or the egg kind of a thing. Maybe the person had pre-existing depression, maybe they had a presence of pre-existing trauma, adverse childhood events that maybe wasn't quite to the level of post-traumatic stress disorder, and then all of a sudden now they've had another traumatic event, and that was kind of the final straw that put them into a state where they meet diagnostic criteria for post-traumatic stress disorder. Another big comorbid disorder is substance misuse or substance use disorders. A lot of times people are trying to self-medicate the symptoms of PTSD with alcohol. If you hear somebody talking about using cocaine and methamphetamine for PTSD, that is unbelievable. It does not treat it. In fact, it makes it worse. So that's very clear that there was some other kind of a disorder that probably pre-existed the PTSD. But very rarely are you going to see people using or misusing stimulant substances unless they're looking for that kind of a high, that adrenaline rush high, which can happen. But most of the time, it's depressant type substances. So alcohol, opioids, benzos, marijuana, sleeping pills, anything that causes central depression. Okay. There's a cost associated with it. We all deal with this in our practices, I'm sure, formulary versus non-formulary. And again, like I said, there's really a limited evidence basis to a lot of the medications that we're prescribing. And quite frankly, there's a limited knowledge of providers, to include mental health providers, about the evidence-based interventions in clinical practice guidelines. In fact, my DNP project looked at that, and it was remarkable to see that folks were not utilizing the clinical practice guidelines and evidence-based practice in their treatment. And again, it's not saying clinical practice guidelines are the end-all be-all, but it certainly is a reference, and it provides us with at least a starting point or additional points if we're considering other medications. So the provider knowledge is really limited as well. All right, so when we talk about the general pharmacological treatment interventions, we're primarily talking about the SSRIs and SNRIs in the antidepressant categories, some mood stabilizing medications. So these are anti-epileptic drugs, Depakote, lamotrigine, topiramate, just to name a few. Antipsychotic medications, which are the second generation antipsychotic medications, Seroquel, Zyprexa, Risperidone, and Abilify, which target both dopamine and serotonin. Benzodiazepines, which are generally contraindicated, that we'll talk about later. other sedating medications to help them get sleep, Ambien, Lunesta, some of the old tricyclic medications, amitriptyline, nortriptyline, beta blockers, propranolol for the acute, hyperarousal response, and then alpha blockers, clonidine and prazosin for re-experiencing symptoms. And we're going to go through these. Okay, so the evidence-based is for antidepressants. Well, most of the RCTs were industry sponsored, so obviously that introduces the potential of some bias. But in meta-analyses, there's been confirmed efficacy over placebo for antidepressant medications. There's only 3 antidepressant medications that are actually FDA approved for post-traumatic stress disorder. Those are Zoloft, Paxil, and Effexor. And what's the problem with a couple of those medications? Well, Zoloft a lot of times can leave people feeling the blues. It's called the Zoloft blues. That people can feel blah, apathetic on it, depending on the dose and that kind of thing. Not an uncommon side effect. Paxil has horrible discontinuation effects if people miss doses, not to mention it's a strong 2D6 inhibitor, so it's going to interfere with other medications that leverage the 2D6 CYP450 enzyme system. And then, of course, Effexor XR kind of falls into that discontinuation syndrome as well. People start missing doses of it, and they're going to feel ill. And so these medications don't necessarily lend themselves very well to adherence because of the potential side effects and drug-to-drug interactions. So we oftentimes are looking at other antidepressants that have better side effect profiles to treat this patient population. So the chronicity of the symptoms may influence the treatment response, meaning that people may end up having these symptoms for a long time, have been on multiple medications, and having they just don't respond to medications, so now they're leery of taking the medications. TCAs, old tricyclic antidepressants, which amitriptyline or triptyline fall into, can be efficacious, but they're not superior in terms of efficacy and tolerability to SSRIs and SNRIs, not to mention the risk that's associated with those medications. The whole reason why SSRIs and SNRIs were developed was because of safety. I have a nephrologist friend who used to tell me that TCAs were a nephrologist's worst nightmare, because if the cardiac stuff didn't kill him, the kidney failure will. So we generally avoid those particular medications in post-traumatic stress disorder. Although there is, potentially some benefit in terms of, chronic pain and managing some of those things. But there's also some SNRIs that are much safer that can also do the same thing. The SNRIs and SSRIs are first-line treatments. I do find that the SNRIs do a little bit better job for aggression and anger, if that's a problem. And oftentimes what we see in post-traumatic stress disorder is that they're either not dosed adequately enough, or they weren't on a long enough trial of medication. And so a lot of times in anxiety, just a general pearl with anxiety disorders, oftentimes we start lower, but they're going to need the higher end of the dosing spectrum, and they may need a longer trial than somebody who has depression. So, if you've got a patient on, let's say, 60 milligrams of duloxetine or Cymbalta, it's only been 4 weeks, give them a good 6 to 8 weeks on that dose and see if they become a late responder. Okay. That's definitely not uncommon, but the patient's looking for relief. They're looking for relief now. And so sometimes our inclination as providers is to go ahead and make the change. But the fact of the matter is they may not have had an adequate trial of the medication. So it's our responsibility to help out with some expectations management about what the person can expect from the medication. Okay, antipsychotics, really mixed results. They are not used first-line treatment. This is really kind of a misnomer. There's really not psychotic symptoms with PTSD per se. It's more of the dissociative feeling, that they're not, in reality and that kind of stuff. It can be helpful for that. Again, we don't use these as monotherapy, but they can be useful for the anger and aggression and sleep as well, and kind of just taking the edge off and getting them some rest. Interestingly enough, Seroquel, we used to use it in our amputee patients because we couldn't use Prazosin because of blood volume issues and issues with orthostatic hypotension. And Seroquel is just as effective as Prazosin, at least initially, for treating nightmares. It has an alpha-1 adrenergic blocking or antagonism capability. And in fact, there was a large study that was done in one of the VAs that compared Prazosin and Seroquel head-to-head, both just as effective, but tolerability and long-term adherence was better with Prazosin than it was with Seroquel because of side effects of weight gain, metabolic symptoms, oversedation, those sorts of things. Mood stabilizers, really, there's not much evidence to support them. One of the topiramate can be as effective as SSRIs or SSRIs and SNRIs. And interestingly enough, I've used topiramate from time to time with folks that have comorbid alcohol use disorders. We're not really sure why it works, but it can reduce the number of drinking days in folks and intake in folks that have alcohol use disorders. Interestingly enough, Prazosin can also do the same thing. And so we will use it for that. The Lamotrigine can be helpful, again, adjunctively in treating any kind of refractory or non-responsive depressive symptoms. And then the gabapentin may be helpful as a non-benzo alternative to helping out with the hyperarousal symptoms. And if the person has chronic pain, can help out with chronic pain as well. Benzos, we generally do not use them. There's no evidence to support them. In fact, they're just a Band-Aid. They mask the symptoms. The person has to have some relative amount of discomfort to be able to make some change. And so we avoid the benzos because all the benzos do, very similar to alcohol, they just put a Band-Aid on it. All right, hypnotics, there's very few studies that say that these medications are helpful for sedation or for sleep related to PTSD. They may help a person fall asleep, but they don't address the nightmares. In fact, trazodone can make nightmares worse. Of course, in males, there's a higher risk of priapism with trazodone. So when you start combining those with alpha-1 antagonists like Flomax, which is a peripherally acting alpha-1 antagonist, you potentially set them up for a higher degree or higher risk of priapism. Some potential pharmaceutical interventions. Ketamine is being extensively studied. It's also being studied in depression. The problem with those things is they generally have to be done on a ambulatory surgery basis. The person requires multiple treatments. And I've actually used ketamine a few times, and in 2 of the 3 cases, the person developed bladder issues where their bladder lining started to slough, and they had blood in their urine, and it can predispose them to a psychogenic bladder. Bladder spasm issues and bladder not emptying like it's supposed to, and potentially bladder cancer. Guanfacine is a blood pressure medication that sometimes can be helpful with some of the hyperarousal symptoms and that sort of thing. The GABA B receptors and NAMDA receptors, like we talked about, and endocannabinoid agonists. There's emerging research being done on those as well. Of course, NAMDA, it's a glutamate receptor site, so effectively blocking glutamate at that particular receptor site. Okay, so let's just transition quickly into combat-related nightmares. And this is something that I have studied extensively and was part of the Prazosin trials with Dr. Murray Raskin, who is kind of he's the national leader international leader really on discovering that Prazosin worked. Dr. Raskin and I were co-investigators on 2 different studies in active duty service members in treating combat-related nightmares with Prazosin. Okay, so really sleep is a core symptom of PTSD, and I think these quotes really do a good job of talking about how sleep is core really in all of our lives. And my favorite one is the last one. Some people talk in their sleep, and lecturers talk while other people sleep. So hopefully that's not the case in this particular lecture. So this is Don, and Don is a Vietnam veteran. He was in the Da Nang Valley, which was the site of a fairly large battle where a lot of American lives were lost, and a lot of North Vietnamese soldiers were lost. And they had dug their fighting positions, and they were sleeping. Some people were awake because they were guarding, and other people were sleeping. And they came under attack, and Don was sleeping, and he woke up, grabbed his rifle, and as soon as he grabbed his rifle, his buddy stood up in front of him. He discharged his weapon, and he shot him through the back of the head, and he killed him. So needless to say, very, very traumatic event. Don survived Vietnam, came back, and really had been drinking and drugging and in and out of the hospital, multiple suicide attempts, for almost 20-something, for about 20 years. And so he was kind of on his last legs, if you will, in terms of treatment and being able to kind of get a handle on his life. And he was in an African-American PTSD treatment group with Dr. Murray Raskin. And Dr. Raskin basically said, we're going to try to get control of this. What can I do to get treatments or to get control of this man's nightmares and some of the hyperarousal experiences he was experiencing? So he went to the PDR, and he was like, well, there's some emerging thoughts about PTSD and norepinephrine, and if you block norepinephrine, maybe that'll be helpful. So he selected propranolol or a beta blocker, and Don came back after being prescribed and said, we're going in the wrong direction. My nightmares are getting worse. So Dr. Raskin said, well, let's try the alpha receptor sites. We tried the alpha-1 antagonist Prazosin. 2 weeks later, Don comes back, says it's the best night's sleep I've gotten in over 30 years, and was finally in the spot to where he could get some treatment. So Don participated in inpatient and outpatient treatment, rehab again, and is now a retired construction owner business, living a very, very happy life. So Don was really suffering for, like I said, 30 years with all of these sorts of symptoms, and it's truly a wonder he did not end up killing himself. Okay, so when we look at the efficacy or the evidence of Prazosin for trauma, nightmares, and global function in Vietnam veterans, there was a placebo-controlled study, a fairly small study, and then a placebo group, parallel group controlled study, again, fairly small group, that demonstrated improvement in sleep duration and quality and a reduction in overall nightmares. In a civilian crossover study, there was positive improvement in sleep duration than there was with placebo, but again, the very small n, and not a robust level of evidence or amount of evidence for the civilian population. A couple of other studies. OIF is Operation Iraqi Freedom, and so this was a study that actually I did while I was downrange. It was a prospective study, and again, a smaller number, but it was the only study that was ever done in a theater of operations, looking at Prazosin and efficacy. And one of the big questions that we had was, is it tolerated in a combat environment? And in fact, it was, and it showed efficacy in sleep duration, quality, reduction in nightmares, and improvement in overall level of functioning. And then the large study that we did, which was really kind of the seminal study, was a double-blind placebo, a randomized controlled trial. We actually stopped the study early because we had more than enough statistically significant information to suggest that Prazosin was indeed effective for treating combat-related nightmares. And in 2013, this was recognized by the New England Journal of Medicine as the 2013 top innovation in psychiatry. And really kind of was a game changer as far as changing how combat-related nightmares were treated. And then here's the study that I alluded to earlier, the Prazosin versus the quetiapine or Seroquel. And Prazosin was much better tolerated, but they were both had similar efficacy. Okay, so when we prescribe Prazosin, one of the things that I often see is that people don't prescribe them, they don't prescribe it high enough. And so really, there's a first dose effect that people can have where they get significant orthostatic hypotension. So we got to be monitoring orthostatics. But if they can tolerate the first, 1 milligram for a couple nights, it's not going to work. But if they tolerate it, then it tells us that we can gradually titrate the medication and we may be okay without having any kind of significant orthostatic issues. So again, what I see is people, they don't dose it high enough, and really it should be dosed 2 milligrams every 4 nights to effect. Most people respond between 4 and 12, 6 and 12 milligrams. When we talk about the dosage of Prazosin for blood pressure, is those of you that have been around a while that might have seen it used for preeclampsia, which it wasn't effective for, and partially because it had to be dosed TID and up to 45 milligrams total a day. So when we talk about Prazosin dose, we're well within the daily dosing and efficacy. Once I get the nightmares stabilized, if they're still having some residual hyperarousal symptoms during the day, you can add on a low dose of 2 to 6 milligrams, and that doesn't cause sedation. It's a great alternative to a benzo, and it can help out. Prazosin isn't necessarily curative for the nightmares, but in some cases it is. I've had people that have taken it for 3 or 4 months, they get other treatment, and they no longer have nightmares. I've had other people that if they don't take their Prazosin, they still have the nightmares despite treatment. So in case you had any questions about is this curative, it really kind of is individually dependent. A couple of tools that we use to evaluate outcomes. The clinician-administered post-traumatic stress scale and the clinical global impression of change. And this is really, the clinical global impression of change is really something that measures their overall, how are they functioning in the world. So it's a combination of objective, what the clinician is seeing, and then what subjectively the patient is reporting. And then the clinician-administered post-traumatic stress scale. Cool thing about this scale is that each item has independent validity, so you can use them individually. The 2 items that we use, or that I use frequently, are the CAPS sleep items. So this really talks about their problems falling asleep, frequency and intensity. It's rated on a Likert scale, gives you some examples of what those are. And then frequency and intensity of nightmares, same kind of a thing. And then you come up with a score, and you can use those 2 measures, those 2 scores to evaluate whether or not Prazosin is effective. In other words, reevaluating them, 4 or 6 weeks, seeing how they're doing. Okay, some of the challenges with pharmacological agents is that the symptom presentation, as we mentioned earlier, is very heterogeneous, and so we really have to focus on what is important to the patient, and that's where the client engagement or patient engagement comes in. We got to meet them where they're at. Okay, I oftentimes ask them, we've talked about a lot of things today. Out of the things we've talked about, what are the 1 or 2 most important things to you that we absolutely address today? Okay, and so that really opens it up for collaborative goal setting, and it gives the patient a sense of ownership in their, in the decision-making process in terms of treatment. And then, of course, lastly, setting expectations, making sure we're managing the expectations. This is how long it's going to take for the medication to work. Here's what you can expect in terms of side effects. If it doesn't work, don't worry. We have other things that we can do. Those sorts of things. Okay. So making sure that we're managing the expectations. All right, standardized screening tools. There's a couple of standardized screening tools. The post-traumatic stress checklist. There's a military version and a civilian version. It's called the PCL. So the military version is the PCLM. The civilian version is the PCLC. And that's a screening tool that we can use to determine the presence of symptoms and if additional assessment is needed. There's also a primary care PTSD screen that's a 4 to 5 item questionnaire, really kind of depending on the version of it, that again tells us if there's the presence of symptoms and if they need additional intervention. Again, screening tools, as we all know, are not diagnostic. They need a diagnostic workup. This is just to indicate whether or not we need to refer them for a potential diagnostic workup. All right, and lastly, or a couple things, two more things. We'll talk about community resources. There's survivor groups, and in terms of treatments, licensed clinical social workers and clinical psychologists. Those are therapists that are trained to provide psychotherapy, and in some cases, many cases, treat post-traumatic stress disorder. They cannot prescribe medication. Okay, they cannot prescribe medication. Only psychiatrists, psych NPs can prescribe psychiatric medications in the context of mental health. For veterans, there's veterans outreach centers, and the purpose of these centers is to take the care closer to the veterans. They're staffed with case managers and therapists to help out with coordinating care and group therapy and things like that assess the veteran with their care and getting care. And then for first responders, there are recovery centers that focus specifically on the the cultural aspects of treating first responders. And I put a link to a website on here called the Institute for Responder Wellness, and they have a ton of resources that are available to help not only providers learn more about treating first responders, but resources that are available for them. And then the National Alliance for the Mentally Ill has a lot of times has local organizations that are probably the most widely available that provide resources on education, treatment for patients, clients, or providers. Okay. Then lastly, I just wanted to talk briefly about care models, because many of you may be seeing these types of care models in your practices. The two types of care models that are kind of out there right now are the collaborative care model and the integrated care model. I prefer the collaborative care model over the integrated care model, because the primary care really is the hub for everything, and that's where our system, our healthcare system, is effectively set up. As primary care kind of drives the train and needs to know what's going on in terms of in terms of treatment. And so patients are managed in the primary care setting, meaning they come to get mental health care at their primary care clinic. That's how my practices work. The workflow is the exact same as it is for a patient coming to see their primary care provider, so that reduces stigma. They're not going to behavioral health clinic if that's something that's stigmatizing for them, and they're treated just like every other patient that comes into the primary care clinic. There's support and treatment offered from mental health providers, whether that is social workers in the clinic, psych NPs or psychiatrists in the clinic. They're really, they collaborate with the primary care. I do prescribe medications, and I do evaluate patients, and I do treat patients, but there's always a clear kind of a pathway for me to communicate with the primary care provider and vice versa. And then care management services, where care is coordinated, patients are followed, and if there's issues, then we can kind of wrap around, the patient and come up with what the best resources are. Integrated care model is similar. Patients are still managed in the primary care clinic, but the primary care provider may not be the team lead. And there may or may not be full integration of mental health providers into the clinic, to include social workers and psych nurse practitioners and psychiatrists. Again, I prefer the collaborative care model, because everybody's involved in the patient care, and to include the patient. And so it's something that you all are going to see, particularly maybe in some of the federally qualified and rural health centers. So I hope that this presentation was helpful, and that you took away some pearls to help you in your clinical practice. Just as a reminder, please complete the post-test so that you can get your CE credit. It's been a pleasure presenting to you all, and I look forward to talking to some of you in the future.